Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Thank you for the kind introduction and the opportunity to contribute in this wonderful conference here. So we were already, discussing, I think in the previous session, there was already, some discussion about gaps in understanding those vulnerable groups of patients, or also mentioned that the elderly are particularly at risk during fasting. So this is a question posed: is age itself, or in fact duration of disease, a risk for fasting? And I think this is important because, of course, I think most of us would assume that the older person would actually be at risk. But we are also now seeing, particularly in my part of the world, many young onset diabetes, and they suffer from long duration of disease, and therefore we understand the complications and consequences. Yeah. So we've also understood just now about the possibility of this paradox. Understanding that in the elderly, we're concerned about, the risk of the extremes of glycemia with advancing age, and with long-standing diabetes, we'll discuss later about the many comorbidities and complications. And we've recently been more familiar with this term called frailty, although most of us may not objectively assess it in daily clinical practice. But we're aware that coupled with elderly age as well as long duration of chronic disease comes a condition of frailty, which puts many older people at risk. But we've also understood just now how fasting, in fact, may be beneficial. And we've heard about the many benefits in terms of improving inflammation and insulin resistance. And as I was sitting there just now, I was wondering, could fasting be the reason many of our older diabetics are doing well as well? And so, that may actually be keeping them. So because we understand in our practice, there are groups of older persons who are so resilient and doing very well. And they are the ones, in fact, who've actually fasted for decades. So I think also alluded as well about the benefits of fasting in other areas. It's particularly anti-aging, as well as the mention of dementia as well. So this is also pertaining to those at the extreme age. So I think we understood from the previous DAR risk stratification, and we noted that in fact age was not set as an independent risk element in the 2021 DAR risk calculator. And I think later you will also see that in the 2026 updated DAR risk calculator, age itself is still not an independent risk element. We understand that age is probably like a surrogate, a proxy for the accumulated risk. So it's not a stand-alone contraindication. It goes without a doubt that as someone has a higher age, there's increased duration of diabetes, and with that, multiple comorbidities, particularly cardio and respiratory disease, and with that also the multiple medications that these patients needed. We saw just now, in fact, in the first session, that those who have longer duration of disease and older are usually on many more glucose-lowering drugs, both oral and injectables. And we know also that these are also the ones that may suffer from counter-regulating hormone abnormalities like hypoglycemic unawareness. So this is from the prior DAR Global Survey. In the initial survey of 2020 publication, we sub-analyzed two different age groups. One was less than 65 and the other older age group of more than 65. And in the combined global survey of 2020 and 2022, in a later publication, there were three different age categories, as can see here: less than 40, 40 to just below 70, and then above 70. And we already appreciated from the session earlier that the prevalence of fasting is generally high. Yeah? But here you can appreciate the difference in prevalence of fasting across the age groups. And it still seems high that the older age category of 70 and above, about 2/3, a little bit more than 2/3 are actually intending to fast and actually fasting. So I pose to you, is that a concern for you? if your patients above 70 are indeed still fasting. So then we look at what are the impact of age. We've sub-analyzed that in those prior studies, and this is in the Global Survey 2020, 2022 put together, sub-analyzed, looking at the impact of age and glycemic events. The extremes, both hypo, severe hypo, as well as severe hyper, and taking that all together. And you can see here in the middle section that severe hypo was really correlated with a different age group. You can see a marked increase in the more than 70 age group at 17.4%, in huge contrast to just below 3% in the younger age group of less than 40. And so this actually age, in fact, this age category strongly predicted this occurrence. But when there was a similar trend with the opposite, which is severe hyperglycemia, so hospital encounters for severe hyperglycemia was also higher in trend, but not significant, and doubling in those with the highest age group, as seen there, almost 12% to about 6% in the younger age group. But when taken into overall account, these hypo and hyper and these extremes of category, as you can see here, is that there was not really much difference, 25% to just about a third of those above 70 having an overall hypo or hyperglycemia. So is it age or is it something else that is actually predicting these higher sort of adverse events of extremes of glycemia? So now let's shift our attention to duration of diabetes and look at what the data says, of duration of diabetes as opposed to just age. So it goes without saying, the longer, I alluded to it earlier, the longer diabetes duration will be associated with beta cell decline, and also accompanying it with increased weight gain, there's also increased insulin resistance, and this leads to more intensive therapies. And this also leads to higher risk of hypoglycemia. And the complications are many, as mentioned before already. And if we think back, you may actually just close your eyes for a minute and imagine the risk calculator of 2021. And where did you actually see the element of duration of disease? If I'm not mistaken, it was the second element, And duration of disease, there was a cutoff of 10 years, seeing that those above 10 years duration of disease would actually score a higher 1, as opposed to those below 10 years. So there was just two categories. And this is going to differ based on the evidence that we've accumulated in the recent years, particularly from the DAR Global Survey of combined 2020, 2021, to actually having another age group that may actually define even a higher risk than what we thought before. So just to remind us, in the combined global survey, we did mention about the differences in glucose-lowering medications. And we had already described this earlier about how the elderly, in fact, you can actually see the distribution of those on the more commoner medications, as read to you. This was the first DAR Global Survey 2020 when we sub-analyzed, this is the second, in fact, or sub-analysis actually of very much elderly versus those that were in the not so older categories. So you have two older categories here, 65 to 75 and more than 75. But it is quite concerning, and maybe it may shift the trend with later years, but quite concerning that there's still an extremely high rate of insulin and sulfonylurea use still in our older patients people living with diabetes. As you can see, more than about 70% are actually still on insulin. So how does duration of disease impact on outcomes? Similarly, we saw about age, how it impacts on glycemia outcomes. So let's have a look at how it impacts on fasting behavior as well as clinical outcomes. So there is a sub-analysis of, now we've introduced less than 10 years that we had before, but now beyond 10 years, we are sub-analyzing 10 to 19 years versus more than 20 years. And you can actually appreciate, and this might match actually their age category, because you can see that the longer they have diabetes, they are actually fasting a little bit less. So probably reflecting what we already described with increasing age. But look at the clinical outcomes. And this, you can see, is quite apparent that those with less than 10 years, less than a decade of disease, 1 in 4 patients had the combined glycemic abnormality of either hypo or hyperglycemia, whereas beyond 2 decades, it was almost 1 in 2 that actually encountered these problems during Ramadan. Yeah. So duration of diabetes in terms of years did actually predict both hypo and hyperglycemia significantly. If we actually look at complications and comorbidities that accompany those with advanced age and duration of disease, we're already probably going to understand that, of course, the older the person, the longer the duration of disease, the comorbidities and complications are also going to appear in a different way, yeah, more so in those who are older and more with duration of disease, both for microvascular as well as macrovascular disease, yeah. So actually, when we are, with that older person with diabetes in our clinic that we encounter in daily practice, you've got to appreciate that it is, in fact, the combination. It's not just their advancing age, but it's also the fact that they're having diabetes longer, when that actually then predicts the higher burden of complications. So this is, in fact, really a higher risk elderly cohort, yeah, that we are describing. And this is where we need more sort of data, especially to actually understand the safety of this vulnerable group to fast, yeah? All right, so frailty is another concept, and you would recognize, in fact, that in the prior or the initial risk stratification, frailty was included as well in one of the risk element categories, yeah, and it will still be included in the current or the latest update, as you will hear later on. It's put together with age and frailty, not as a separate sort of element to consider, yeah? But frailty is something important that we need to appreciate when we deal with this group of people that we're talking about, and actually how to assess is important. It's not just actually a general impression, but using objective scores that are validated would be important. And there has been clinical study and publication using a validated tool for Ramadan, in particular among the older persons, using the frail tool, yeah? So in fact, it is appreciated that actually we should be using these specific tools to actually assess the frailty level among our patients and therefore appreciate their risks. So in this publication, just last year by Latifah, together we contribute to the chapter or section, in fact, on older persons, duration of disease and frailty for the coming guideline of 2026. And in her group did actually use the frailty or frail tool and describe, in fact, that those who are frail, 1 in 3 had an adverse event during Ramadan. These are among the diabetics. And you can see and appreciate that there is that difference in those who are pre-frail versus those that are robust. Yeah? And we need to go back to the definitions of this. So the risk, in fact, of getting an adverse event during Ramadan was more than 5 times higher in the frail patients compared to the robust patients. There has also been some studies prior, because we are concerned in the older person, yeah, who actually is fasting. We are worried about sarcopenia and muscle loss. And this very small study from Turkey in 2019, where they took individuals who were older and looked at their fasting, and how it affects their muscle mass. It was found that within the Ramadan period of fasting, following that, using different measures, that there was no significant impact on their muscle function as they measured. And nutrition was very important to actually prevent the loss of muscle. So conclusion-wise is actually it's not the individual factor of just age, but you have to take into account age, together with duration of disease in the elderly person, and in fact put in the equation frailty as well, if we could do this objectively, would be the most important way to actually assess the risk of an older person fasting. So just a flash, because I know it's going to be talked about in great detail, but it's the updated risk calculator has the same 14 elements, but it's more, you can see, it's a bit difficult maybe to appreciate from there. I'm sure Dr. Hussain will explain it in more detail, but just to appreciate that now for duration of diabetes, again, age in specifically is not an element, yeah, but duration of disease now has 3 categories: less than 10 years, 10 to 20, and more than 20. And just to show that last bit, if possible, that the other category here, sorry, it's not coming up, and the advanced age and frailty is put together in the 11th sort of element of cognitive function, frailty and age, and only a number of 70, above 70 is put there with no home support. But frailty is now expressed either as advanced frailty, which has such a high score of 6.5, putting the person definitely at high risk, or mild to moderate frailty with a score of 4. Yeah. So the issue is now how we're going to assess the frailty in a clinical context. So this is the last slide, but this is, I think, the management of any person in Ramadan, also the same equation of the pre-Ramadan risk assessment for the older person, the education that is important, which is individualized, monitoring of glucose, medication adjustment, because they're still using medications with high risk of hypos. But we must acknowledge that they have a right to fast. Many of them have fasted well and are doing well and probably protecting themselves. Just the very final slide, thank you, which actually, I'm out already, but okay, the final slide was just to tell you all about our Diabetes in Ramadan conference that is happening next weekend. And if you would like to join us virtually, do scan and join us as well. Thank you very much.
Thank you. Thank you.